Let's begin our journey into the anatomy of the hip joint. The hip is one of the most important joints in the human body. It allows us to walk, to run, to climb stairs, and even to simply sit down comfortably. Without the hip joint working properly, every movement of the lower limb becomes a challenge. Now, what kind of joint is the hip? Technically speaking, it is a ball and socket type of diarthrodial joint. That sounds complicated, but let's break it down. Ball and socket means that one side of the joint is rounded, like a ball, and it fits into a hollow cavity, like a socket. Think of how a pestle fits into a mortar, or how a joystick moves inside its base. Diarthrodial means it's a synovial joint designed for free movement. In fact, it's one of the most mobile, yet also one of the most stable joints we have. But here's something fascinating. Unlike the shoulder, which is also a ball and socket type of joint, but prioritizes mobility, the hip is designed to prioritize stability. After all, it has to carry almost the entire weight of our body, especially when we stand on one leg, like during walking. So, where does this stability come from? It's conferred in three main ways: bony architecture, the deep socket of the acetabulum, which embraces the femoral head almost like a cup holding a sphere; acetabular labrum, a ring of fibrocartilage that deepens the socket and acts like a suction seal holding the femoral head in place; and hip capsule and ligaments, strong fibrous tissue and some of the strongest ligaments in the body, which further secure the joint. Let's zoom in to the acetabulum, the socket side of the joint. The acetabulum isn't just a single bone. It's formed from the fusion of three ossification centers: the ilium, which is the large wing-shaped bone you can feel at your waist; the ischium, the bone you sit on when you're in a chair; and the pubis, located in the front, forming part of the pubic symphysis. These three bones come together like puzzle pieces, and their fusion creates the acetabulum. If you look closely, you can even see the Y-shaped cartilage line in children, called the triradiate cartilage, which eventually fuses in adolescence. Another interesting point: not all the acetabulum is equally built. The posterior-superior portion has thicker cartilage, and that's for a very practical reason. It bears most of the body's weight every time you stand. The forces of gravity push the femoral head into the acetabulum, and this area is reinforced to handle that load. So, to summarize this first part, the hip is a ball and socket diarthrodial joint designed with stability as its priority. Its stability comes from the deep bony socket, the acetabular labrum, and the powerful capsule and ligaments. The acetabulum itself is a fusion of the ilium, ischium, and pubis, with its weight-bearing region reinforced by thicker cartilage. Now that we have an overview of the hip joint, let's move deeper into the osteology, or the study of the bones that form this region. To understand the hip properly, we need to focus on two key components: the acetabulum and the proximal femur. The acetabulum is the socket part of the hip joint, located on the lateral surface of the pelvis. One important detail:
The acetabulum is not facing straight sideways. Instead, it is anteverted about 15 degrees, which means it points slightly forward. This orientation is crucial for proper hip motion. Imagine a car tire slightly turned outward. That little angulation changes how forces are transmitted through the wheel. The hip works the same way. In addition, the acetabulum is abducted about 45 degrees, which we sometimes call the caudal tilt. This tilt allows the socket to cover the femoral head in a way that balances mobility and stability. Surgeons often divide the acetabulum into 4 quadrants when planning screw placement, especially during pelvic or acetabular fracture surgery. How do we get these quadrants? First, imagine a line drawn from the anterior superior iliac spine, or ASIS, through the center of the acetabulum. This gives us an anterior and posterior half. Then draw another line that crosses it perpendicularly through the same center. Now we have 4 regions: posterior superior, posterior inferior, anterior inferior, and anterior superior. Why is this important? Because each quadrant has different vessels and nerves running through it, and that means different levels of safety when placing hardware. The posterior superior quadrant is the safest zone for screw placement. Here we find the superior gluteal nerve and vessels, as well as the sciatic nerve, but they lie further away from the bone, giving surgeons more room to work. The posterior inferior quadrant comes next in terms of safety. It houses the inferior gluteal nerve and the internal pudendal vessels. The anterior inferior quadrant is unsafe because it contains the obturator vessels, which can be easily injured. And finally, the anterior superior quadrant is also unsafe, since it contains the external iliac artery and vein, which are major vessels. So, a quick rule of thumb: screws go safely posterior superior first, posterior inferior second, but avoid the anterior quadrants. Now let's shift to the femur, the longest bone in the body. We are interested mainly in the proximal femur, the part that articulates with the acetabulum. At the very top, we have the femoral head. Ideally, the center of the femoral head should align at the level of the tip of the greater trochanter, which is a large bony prominence on the side of your hip that you can often feel under the skin. Extending from the head is the femoral neck. This is not aligned perfectly with the shaft. It has 2 important angles. It is anteverted about 15 degrees relative to the femoral condyles, which means the femoral neck points slightly forward compared to the knee joint. This anteversion helps with natural hip motion like walking. It also forms a neck shaft angle of about 125 degrees. Too wide or too narrow an angle can cause deformities or hip problems. For example, a decreased angle is called coxa vara, while an increased angle is called coxa valga. Next, the greater trochanter and the lesser trochanter are 2 major landmarks. The greater trochanter projects laterally, serving as a powerful lever arm for muscles like the gluteus medius and minimus, which stabilize the pelvis when walking. The lesser trochanter, on the other hand, is located medially and posteriorly, acting as the insertion point for the iliopsoas muscle, the main hip flexor. These trochanters are not just anatomical curiosities. Surgeons use them as essential landmarks in hip replacement surgery, fracture fixation, and even when interpreting radiographs. Practical takeaway. So, to summarize, the acetabulum is oriented 15 degrees forward and 45 degrees tilted outward. It's divided into 4 quadrants, with the posterior superior region being the safest for screws. The proximal femur has a head, neck, and shaft, with a 125-degree neck shaft angle and 15 degrees anteversion. The greater and lesser trochanters serve as key muscle attachment points and surgical landmarks. Understanding this osteology is not just academic. It has direct surgical and clinical applications, from interpreting X-rays to safely placing hardware in the operating room.
Now that we've covered the bones of the hip, let's move to something just as important: the capsule and ligaments of the hip joint. These structures are what truly keep the hip stable during daily activities, especially when we're putting weight on one leg or extending the hip behind us. The hip joint capsule. The hip joint capsule is a strong, fibrous sleeve that encloses the joint. Think of it like a tough envelope wrapping around the femoral head and the acetabulum. It attaches anteriorly along the intertrochantic line. That's the ridge on the front of the femur just below the neck. Posteriorly, it attaches along the intertrochantic crest. This difference is important because it means that certain regions of the femoral neck, like the basicervical and intertrochanteric regions, are actually extracapsular, and this has direct surgical implications. Fractures in these regions behave differently than intracapsular ones. The 3 main ligaments. Inside and outside the capsule, the hip is reinforced by 3 major ligaments. 1. Iliofemoral ligament, the famous Y ligament of Bigelow. This is the strongest ligament in the body. It runs from the anterior inferior iliac spine, AIIS, down to the intertrochanteric line. When the hip is fully extended, like when you're standing upright, it becomes taut, locking the hip into place and preventing hyperextension. Why is this so important? Because it means we can stand upright with very little muscular effort. The ligament is literally holding us in place, saving energy. Clinically, it's also critical because it helps prevent anterior dislocation of the hip. Ischiofemoral ligament. This one reinforces the posterior capsule. It's not as strong as the iliofemoral ligament, but it resists excessive internal rotation and posterior translation. When surgeons approach the hip posteriorly, they're very aware of this ligament because cutting through it can increase the risk of posterior dislocation after hip replacement. Pubofemoral ligament. This ligament reinforces the inferior and anterior part of the capsule. It prevents excessive abduction and extension. Think of it as the check rein that keeps your leg from moving too far outward. Other supporting structures. Ligamentum teres, also called the ligament of the head of the femur. It runs from the cotyloid notch of the acetabulum to the fovea on the femoral head. In adults, it doesn't provide much mechanical stability. It's relatively relaxed during hip adduction. But in children, it's more important, as it carries a small artery that supplies blood to the femoral head. Transverse acetabular ligament. This is located at the inferior margin of the acetabular labrum, spanning the acetabular notch. It doesn't provide major mechanical restraint, but it is an important anatomic landmark during surgery. For example, when surgeons ream the acetabulum for a total hip arthroplasty, they use this ligament to assess acetabular version and orientation. So to tie this together,
The capsule encloses the hip, attaches anteriorly to the intertrochanteric line, and posteriorly to the crest. The iliofemoral ligament prevents hyperextension and anterior dislocation. The ischiofemoral ligament reinforces posterior stability. The pubofemoral ligament prevents excessive abduction, and the ligamentum teres has limited importance in adults but a vascular role in children. And the transverse acetabular ligament is a landmark for surgeons. Together, these structures transform the hip joint into one of the most stable joints in the human body, strong enough to bear our entire body weight, yet flexible enough to let us run, jump, and pivot.
When we talk about the hip, one of the most critical things to understand is its blood supply. Why? Because interruption of that supply is one of the main reasons patients develop avascular necrosis, or AVN, of the femoral head. Changes with age. The pattern of blood supply to the femoral head changes as we grow. From birth to about 4 years of age, the femoral head is supplied by 3 sources: the medial circumflex femoral artery, the lateral circumflex femoral artery, and the artery within the ligamentum teres. At this stage, the artery of the ligamentum teres still plays an important role. From about 4 years to adulthood, the supply becomes more dependent on the retinacular vessels, especially the posterior-superior and posterior-inferior branches of the medial femoral circumflex artery. These vessels run along the capsule and penetrate the femoral head. And here's the clinical pearl. If these posterior-superior retinacular vessels are damaged, for example, by a fracture or a poorly placed surgical nail through the piriformis start point, this can cause AVN of the femoral head. In adults, the mediofemoral circumflex artery is the major blood supply. That's why surgeons take great care during posterior approaches to the hip. If the quadratus femoris is transected carelessly, it can injure this artery. Meanwhile, the artery of the ligamentum teres, which was important in childhood, has very little significance in adults. It's a remnant rather than a lifeline. Key arteries around the hip. Now, let's trace the major vessels. The abdominal aorta branches into the external iliac artery, which continues as the common femoral artery. This vessel is actually at risk during screw placement in the antero-superior quadrant of the acetabulum during hip arthroplasty. The profunda femoris artery branches into the lateral circumflex femoral artery, whose ascending branch is at risk during the direct anterior approach. The medial femoral circumflex artery, the major supplier of the femoral head. This artery is endangered during psoas tenotomy or deep posterior dissection. The femoral artery perforators supply the vastus lateralis muscle and can be a source of bleeding during lateral approaches. From the internal iliac artery, we get the posterior branch of the obturator artery, which supplies the transverse acetabular ligament. This artery can be injured with screw placement or retractors in the antero-inferior quadrant of the acetabulum. The superior gluteal artery, which exits the pelvis above the piriformis, supplying the gluteus medius, minimus, and part of the maximus. This vessel is critical during approaches that go through or around the gluteal muscles. The inferior gluteal artery, which supplies the short external rotators and part of the gluteus maximus. It runs below the piriformis and can also be injured during posterior approaches. The internal pudendal artery, which interestingly leaves the pelvis through the greater sciatic notch and then re-enters the pelvis through the lesser sciatic notch. Corona mortis, crown of death. Finally, let's not forget the corona mortis. This is a vascular connection between the inferior epigastric artery from the external iliac and the obturator vessels. The name crown of death is not an exaggeration. If a surgeon encounters this vessel during a pelvic operation or even hernia repair and injures it without realizing, the bleeding can be catastrophic. This is why every surgeon who operates in the pelvis must remember it. Practical summary. Children rely on the medial and lateral circumflex arteries plus ligamentum teres. Adults depend mainly on the medial femoral circumflex artery. Injury to the posterior-superior retinacular vessels is a key cause of AVN. Surgical approaches must always respect these vessels. Posterior approach, protect the medial femoral circumflex artery. Anterior approach, be mindful of the lateral circumflex femoral artery. Quadrant rule, avoid major arteries when placing acetabular screws. And always beware the corona mortis, the hidden danger of pelvic surgery.
When we talk about the hip joint, we cannot ignore its nerve supply. After all, nerves are not only responsible for movement and muscle control, but also for sensation and pain patterns. And in the hip, these patterns can be tricky because pain is often referred to distant locations, like the knee. The lumbosacral plexus. The hip is innervated by the lumbosacral plexus, which is formed from the T12 to S4 nerve roots. This plexus lies posterior to the psoas muscle and branches out like a highway system, sending nerves to the anterior, medial, and posterior compartments of the thigh. Posterior division. From the posterior division, we get some very important nerves. The sciatic nerve. This is the largest nerve in the body and is actually a combination of two divisions, the peroneal or lateral and the tibial or medial. Clinically, this is the most commonly injured neural structure during total hip arthroplasty, THA, especially with the posterior approach. Why? Because the sciatic nerve runs deep to the long head of the biceps femoris, very close to the operative field. Injury here can cause devastating deficits like foot drop. The superior gluteal nerve supplies the gluteus medius, gluteus minimus, and tensor fascia lata muscles. These muscles are critical for pelvic stability during walking. If this nerve is damaged, the patient develops a Trendelenburg gait. The hip drops on the opposite side when standing on one leg. The inferior gluteal nerve supplies the gluteus maximus, the main extensor of the hip, crucial for climbing stairs or rising from a seated position. Posterior femoral cutaneous nerve provides sensation to the posterior thigh. Anterior division. From the anterior division, we get the tibial nerve, the medial part of the sciatic, controlling posterior thigh and most of the posterior leg muscles. Nerve to quadratus femoris and nerve to obturator internus, small but important branches that help control the deep external rotators of the hip. Pudendal nerve, which exits and re-enters the pelvis, innervating the perineum. Coccygeus nerves, supplying the coccygeus muscle. The obturator nerve, one of the most clinically important nerves for the hip joint. It innervates the medial compartment of the thigh, all the adductors except the hamstring portion of the adductor magnus. Because of its articular branches to the hip joint, irritation here can cause referred pain to the knee. This is why a patient with hip arthritis sometimes comes to the clinic complaining of knee pain, even when the knee is perfectly normal. The femoral nerve. The femoral nerve runs between the iliacus and psoas muscles. It gives off branches not only to the quadriceps, but also to the skin and to the hip joint itself. Clinically, it's at risk during anterior approaches to the hip or with retraction in pelvic surgery. Sensory branches. Two smaller nerves deserve mention. The lateral femoral cutaneous nerve, derived from L2-L3, this nerve runs deep to the inguinal ligament near the ASIS. It's vulnerable during anterior approaches, particularly the direct anterior approach to THA. Injury here causes meralgia paresthetica, burning pain or numbness over the outer thigh. The genitofemoral nerve, from L1-L2, splitting into a femoral and a genital branch. It pierces the psoas and runs along its surface. It's a small nerve, but important to know during retroperitoneal and pelvic surgeries. Practical clinical pearls. The sciatic nerve is the most commonly injured nerve during THA, especially with posterior approaches. The superior gluteal nerve injury results in Trendelenburg gait. The obturator nerve influences medial thigh motor function and referred hip to knee pain. The lateral femoral cutaneous nerve is particularly vulnerable during anterior approaches, so remember the risk of meralgia paresthetica. Always remember, hip pain can be felt in the knee because of shared innervation. So, the neurological anatomy of the hip is not just an academic list of nerves. It explains surgical risks, post-op complications, and even why patients often feel pain far away from the hip itself.
The hip isn't just a ball and socket joint. It's a powerhouse of movement. Every step we take, every time we climb stairs, sit, or kick a ball, dozens of muscles are working in perfect harmony. To make this easier, let's break the muscles down into functional groups: flexors, extensors, abductors, adductors, and external rotators. I'll also give you a few mnemonics along the way to help you remember them. 1. Hip flexors. The hip flexors are the muscles that bring the thigh forward, like when you walk upstairs or lift your leg to put on socks. The key players are iliopsoas, the most powerful hip flexor. It's actually two muscles, the psoas major and the iliacus, which merge and insert into the lesser trochanter. Think of it as the engine of hip flexion. Rectus femoris, one of the quadriceps, crossing both the hip and the knee. That's why it flexes the hip and extends the knee. Sartorius, the longest muscle in the body, running diagonally across the thigh. It flexes, abducts, and externally rotates the hip, a movement combination we jokingly call the tailor's position, like crossing your legs. Pectineus, located near the groin, it flexes and also adducts the hip. Iliacus, often considered part of the iliopsoas, but worth mentioning separately. Key mnemonic for hip flexors: I really saw people inside. That's iliopsoas, rectus femoris, sartorius, pectineus, iliacus. 2. Hip adductors. The adductors pull the thigh toward the midline, like when you squeeze your knees together. They're located in the medial compartment. The main ones are adductor magnus, the adductor portion, the largest and most powerful; adductor longus, long and more superficial, often injured in athletes with groin strains; adductor brevis, a short adductor sitting deep to the longus; adductor minimus, sometimes considered a part of adductor magnus but worth noting separately; gracilis, a thin, strap-like muscle that also flexes the knee. Key mnemonic for adductors are: all boys must love girls. Adductor magnus, brevis, minimus, longus, gracilis. Clinical pearl. Adductor longus injuries are common in soccer players due to sudden forceful adduction. 3. External rotators. These muscles rotate the hip outward, like when you point your toes to the side. They're sometimes called the short external rotators, and they're surgical landmarks during hip replacement. They include gluteus maximus, the largest muscle of the hip. Besides being an extensor, it also contributes to external rotation; piriformis, running from the sacrum to the greater trochanter, clinically important because the sciatic nerve passes just below it; obturator externus, obturator internus, superior gemellus, inferior gemellus, quadratus femoris, a strong square-shaped muscle. Key mnemonic for external rotators are go, poix. That's gluteus maximus, obturator externus, piriformis, obturator internus, quadratus femoris, superior and inferior gemelli. Clinical pearl. These small muscles act like rotator cuff muscles of the hip, stabilizing the femoral head inside the acetabulum. 4. Hip abductors. Abductors move the leg away from the midline, like when you spread your legs apart. They're critical for gait. The key muscles are gluteus medius, the most important abductor, also stabilizes the pelvis when standing on one leg; gluteus minimus, a smaller, deeper version of gluteus medius; tensor fasciae lata, or TFL, located on the lateral thigh, blending into the iliotibial band. Clinical pearl. Damage to the superior gluteal nerve paralyzes these adductors, causing Trendelenburg gait, where the pelvis drops on the opposite side. Key mnemonic for adductors are make my tailor. 5. Hip extensors. The extensors pull the thigh backward, like when you rise from a chair, climb stairs, or sprint. They include gluteus maximus, the powerhouse of hip extension. Without it, climbing stairs would be almost impossible; hamstrings, the semitendinosus, the semimembranosus, and the long head of the biceps femoris. These extend the hip and flex the knee. Adductor magnus, the hamstring portion, often forgotten, but it contributes as well. Key mnemonic for extensors are good, strong, ham, add. That's gluteus maximus, semitendinosus, hamstrings, that's the semimembranosus and the biceps long head, adductor magnus, the hamstring portion. Clinical integration. Hip flexors are tested when asking a patient to lift their thigh while seated. Weakness suggests femoral nerve injury. Hip adductors, weakness may indicate obturator nerve damage. External rotators are important for hip stability during surgery. Injury can cause increased risk of dislocation after arthroplasty.
Hip abductors are essential for walking. Superior gluteal nerve damage equals Trendelenburg gait. Hip extensors are essential for propulsion. Weakness equals difficulty standing or climbing stairs. Closing. So, to sum up, the muscles of the hip can be remembered with a few mnemonics. Flexors. I really saw people inside. Adductors. All boys must love girls. External rotators. Go pox. Abductors. Make my tailor. Extensors. Good, strong, ham, add.